So good morning, everyone. My name is Lieve van den Blok. Thank you for the introduction, but my country is Belgium and not the Netherlands, I should say. But let's prove that. Because I'm from a university that's based in Brussels and in Ghent. We are a group of researchers, a relatively young group of researchers studying palliative and end-of-life care research, and I'm presenting some of the results that we did in a European study which is called PACE. And it's really difficult to summarize or highlight a few of the findings of a large study, but I'll try. So what is actually the challenge that we try to address in this study? Consider Mrs. White. She's 80 years old. She lives at home with a husband. At the left of the figure, you can see she develops chronic heart failure, diabetes, and she's considered frail. Over the course of time, she also develops Alzheimer's dementia. And at a certain moment in time, she develops behavioral and psychological problems, and she's admitted to a nursing home. Over the course of the last year of her life, she's hospitalized a number of times before she dies. Now, this is, in my field, the palliative care research field, what we consider a frailty or dementia end-of-life trajectory. It's relatively unpredictable, there's a gradual decline, and you have multiple physical, psychosocial, and spiritual or existential needs fluctuating in intensity over time. Now, the old model of palliative care, which exists already for a very long time, is a model that says palliative care is actually terminal care. It's something for the last days and weeks of life. But that's a model that's not really suitable for trajectories such as people who are frail or who develop dementia. And so the new model, which has been advocated by a number of organizations, including the World Health Organization, for over a decade, I believe, is a palliative care approach across the trajectory. It doesn't mean that everyone needs specialist palliative care services. It means a palliative care approach to dealing with people, an early integration, even alongside life-prolonging treatments. And that's why the definition of palliative care is actually not about dying, it's about living well. It's an approach to improve quality of life of all people living with life-threatening illnesses and of their families. So palliative care is advocated as a patient-centered and a family-focused care. There has been a recent white paper, if you're interested in that, from the European Association of Palliative Care on the applicability of palliative care in dementia. It's published in Palliative Medicine. And we have also written a book with Oxford University Press on palliative care for older people, a public health perspective, highlighting the need for palliative care in dementia and particularly also in nursing and care homes. And that's actually the basis of my talk today, palliative care in care nursing homes. So the EU PACE project. So it's an EU-funded project under the 7th Framework Programme. The countries in green are the ones where we collected data, so Finland, Poland, Italy, Belgium, the Netherlands and England. We have a wide range of partners in these countries and of course also important international organizations such as Alzheimer Europe, Age Platform and European organizations of professionals. So we actually, in PACE, we did two big studies, a descriptive study and an intervention study. So trying to see what's the state of the art now in these countries and how can we improve. The overall term we often use is long-term care facilities, but that's too long for this talk. So I'll talk about nursing homes, but it includes all types and forms of nursing and care homes across Europe because you have a variety of different names. So how are we actually doing in nursing homes? The first study, the descriptive study, we drew representative samples of all these different types in different regions in these 6 countries. And what we did is we asked the staff in these facilities to list all deceased residents over a period of 3 months. We send out questionnaires to the staff member most involved, the relative most involved, and the treating physician, which was often a general practitioner. That's the first cross-sectional study of deceased residents. And they filled in questionnaires on quality of care and quality of dying. And a second part was a cross-sectional study of staff. So we had all staff in these nursing homes responding to questionnaires to evaluate their knowledge of palliative care and their attitudes. In total, we had 1,701 deceased residents identified in 322 nursing homes. On the right, you see we have relatively good response rate across the different countries. They vary somewhat between the countries. They were very high for staff, a bit lower for relatives, but still rather high, I feel, in many countries. 66% of the identified residents were female and a third was over 90. The mean age was 85. That differs a bit between countries, especially Poland, where people are dying a little bit younger. And there's also a difference in Poland when it comes to the median length of stay. So that varies between 5 months on average, median length of stay in a nursing home in Poland, to 25 in Belgium. It also differs a bit in terms of types, but I won't give you these details, but it's important to know you have a very different case mix in these settings, a different population also. So what about dementia? How often did people have dementia in nursing homes? These are the percentages where GPs or nurses indicated that there was some form of dementia. So as you can see, the orange bars are the percentages of people that have dementia in the different countries, and that ranges from 58% in England to 83% almost in Finland. So a huge difference there, but also when we asked to fill in some clinical scales to evaluate the stage of dementia, we identified people with advanced dementia in this group in half of the cases or higher. In Poland, up to 64% of people were identified in the last month of life as having an advanced form of dementia. But not all, importantly. Many people also in not an advanced form. So how did the staff rate the quality of dying? We used a scale which is validated for this group of patients, the comfort assessment while dying. It assesses scales, items such as discomfort, pain, shortness of breath, choking, difficulty swallowing, anxiety, crying. Higher scores mean better quality of dying. These are the overall figures for the different countries. So you do see some differences, with England scoring a little bit higher, but as our previous speaker also said, it's also important to highlight things across the different countries, because you can see the blue, it's not that bad, but you also have room for improvement in all of these countries. And if we looked at the scale items, particularly the ones that were the worst, concerned evaluations of discomfort, pain, difficulty swallowing, and patients not being calm at the end of life in the last week, as evaluated and observed by staff. So we also wanted to see, next to these symptoms, whether opioids, for example, were used in the last 3 days of life. And we took all the patients where the staff said there was somewhat or a lot of pain or dyspnea, because these are two symptoms where opioids are indicated. And if there was somewhat or a lot of pain or dyspnea in the last week of life, were opioids used. So I'll show you the percentage of opioid underuse, where there was pain but no opioids used in the last 3 days of life. So there were huge differences between the countries, as you can see. Every country reported underuse of opioids, but in particularly Italy and Poland scored relatively bad on this indicator. We also had an elaborate evaluation of the quality of end-of-life care in the last month of life. Without showing all the details, I think a consistent pattern in this quality of care in the last months of life using this quality of dying in long-term care scale was that the nursing home care relatively scored well in all countries. Good nursing home care, for example, in terms of presence of a nurse with whom a resident felt comfortable, dignity was maintained, body and clothes were kept clean, while most room for improvement was found for advanced care planning, having treatment preferences discussed and in writing, decision makers named, but also residents indicating that they were prepared to die or appear to be at peace. So the preparation and the advanced care planning part was something consistently less well than the regular good nursing care in all the countries. And we also looked at this data specifically, do we see differences whether people develop dementia or not? And in most of the scales we didn't find a lot of differences, so that's why I'm discussing everything for all residents in the homes. So that was the first part, looking at the deceased residents, but we also asked the staff a lot about what do they know on palliative care. Who is the staff responding? We had 2,275 staff members. The orange ones are the nurses. So as you can see, in Finland and in Italy, we almost have all nurses working in these care or nursing homes, or equivalent degrees. While in Belgium, in particular the Netherlands, and also in England and in Poland, we had a lot of care and nursing assistants. And that makes providing care for people very different. So that's why I'm splitting the results a bit depending on who responded to our survey. One important element was, do they know a lot about end-of-life care? So higher means scores on a scale from 0 to 1 means better knowledge again. So we used vignettes to evaluate what they knew about measuring and treating pain at the end of life, about death rattles, end-of-life decisions, dying signals. So these are the overall scores in the 6 countries, split for the nurses and the care assistants. So the nurses are the orange ones. So you can see for every country, nurses score relatively better every time than the care assistants. But the difference is not that big. There is a difference. You also see that Poland and Italy, because I ranked them in terms of scoring, do not have that well of knowledge on palliative care and end-of-life care than the other countries. But again, you see room for improvement. There's quite some white space on the top in every country. Next to knowledge, we also had some questions on attitudes, and I thought this one was particularly relevant for you as an audience. We asked the staff, with regard to care and treatment, I feel that palliative care is important to older people with Alzheimer's disease or dementia. On a 5-point scale, strongly disagree to strongly agree. So these are the percentages in all the different countries where nurses and care assistants indicate that they moderately or strongly agree with this statement. So a lot in many countries moderately or strongly agree that palliative care is important for people with dementia. But again, you see differences between the countries, and they're ranked approximately in the same order than I mentioned before, with Italy and Poland at the end. But if I would give you the figures of strongly agree, it would drop considerably. So there are still a lot of staff members that do not feel that palliative care is important for people with dementia also. So based on some of these figures and a lot of other material, which we will publish, I hope, in the forthcoming months, is that we feel that there's still a long way to go towards this new model that I've suggested in the beginning. And we really need evidence-based models for general palliative care, a general palliative care culture in nursing homes. And that is why, as part of PACE, we have developed an intervention which is called PACE Steps to Success. It's basically a 6-step program with a lot of facilitation, trying to introduce general palliative care principles in the nursing homes. It looks a bit like this if you make a picture out of it. I won't have time to go through the details, but I do invite you to visit our website to find out a little bit more already. It goes from advanced care planning to care after death. It's about introducing some principles and coordinative activities and scales to measure and evaluate how people are doing. But it works with external trainers and people on the floor, which we call PACE coordinators, who have to actually do this intervention with the support of a trainer. And it takes a whole year to implement. So the first results will only be coming out next year. So my key messages for today. The data, and this is what we keep on stressing and think is really very important, that palliative care, providing good quality palliative care in nursing homes, is a very big public health challenge. And the fact that people are staying shorter in these homes, there is really a decrease in the length of stay. And you see that in a number of European countries, and an increasing number of people with dementia, and enlarges this challenge a lot. The data also suggests room for improvement. In some countries maybe a little bit more than in others, but actually room for improvement in a lot of countries, in terms of the comfort provided in the last week of life, in terms of advanced care planning, in terms of staff knowledge on palliative care. And if we analyze, if we look at Poland and Italy, those are actually also the country where palliative care is less developed in the nursing home setting itself. Poland, for example, is a country where palliative care is relatively well developed within the home care and the hospital, but not in the nursing home. And that really makes a difference, to have strategies or policies that also focus on this setting and to enhance palliative care. And then thirdly, to really address this problem, there is no quick fix. And that is why our PACE Step to Success program is such a big multi-component training program, which we already know has a lot of challenges to implement and to change a culture which is currently in such a setting. So thank you for your attention.